It's my pleasure to be here. And the main discussion today is going to be low back pain, evaluation, management, and return to the workplace. And we'll try to use some evidence-based guidance to kind of help get us through this topic. So, a few learning objectives. We want to review the prevalence and the economic impact for low back pain, and especially low back pain in the workplace. Understand some key risk factors that are occupational hazards that can result in this, and come up with a rubric to evaluate low back pain and identify specific red flags or yellow flags, which we'll talk about, that can help with timely referrals and management and imaging studies and image guidance. We're going to apply some evidence-based strategies on how to treat patients with, acute, subacute, and chronic low back pain, and then come up with some, guidance on promoting safe return to work and injury prevention at large. So let's discuss the scope of the problem. So everybody, on this probably Zoom call knows that low back pain is the leading cause of workplace disability. It's a common reason why most people seek out, it's actually the second most common reason why people seek out healthcare in general, and up to 80% of adults at some point in their lives will experience low back pain. And most of it will self-resolve. Only a few percentage of patients will need further treatments. And each year, about 4% of the adult population in North America will have an episode of low back pain. And 8 to 10 million people seek out treatment yearly, which is a fairly significant number. And some of these numbers are actually older, so these numbers are growing as we have a little bit more of an aging population and aging workforce. And 6 to 8 million people are permanently disabled due to low back pain. So there's clearly an economic cost to this, and that reaches about $100 billion or more in direct and indirect costs to the healthcare. So what are some of the workplace factors? Some things to think about is, as I was looking through some of these risk factors, some professions were not surprising to be on the list, and some were, I think, of interest to this group. So construction, heavy manufacturing, transportation, things like that, you expect it. But healthcare is one of the most common professions where you see reported low back pain and disability due to low back pain. And I'm sure you guys see plenty of this in your practices and in your day-to-day kind of patient interactions. So there's various risk factors: repetitive lifting, twisting, if you're working with vibration tools. So again, construction people, but psychosocial stressors, job dissatisfaction, and work-related workplace stress, they're big risk factors, and that should be part of our, initial history and patient counseling. So looking at etiologies for back pain, well, mechanical back pain is a pretty typical one that, we'll all be facing with in occupational medicine, but also in general medicine, of course, in spine. We see this all the time. And there's a range for why people have mechanical back pains. It's someone with a sprain or ligamentous or muscular injury or sprain, and those generally self-resolve with, time and mild physical therapy and treatment. But this could also be spondylosis or arthritis, including facet disease, or discogenic back pain, which is either due to a herniation or just due to age and degenerative changes. When back pain is accompanied by neurologic issues, we worry about, nerve compression, stenosis, radiculopathy, and that's important to rule out because the treatments for that and the rubric for that is slightly different than just an acute onset of mechanical back pain. It's also important to get a thorough medical history, make sure there's no risk factors for non-mechanical pain, such as tumors, inflammatory systemic diseases, or infections. And those can sometimes present as run-of-the-mill back pain, but there's something more nefarious underlying. So it's important to weed that out and suss that out actually in your history. So occupational risk factors, again, this group probably is pretty well familiar with this, but the vast majority of back pain claims, they don't happen due to a catastrophic injury, like a construction injury or a fall from, major height, things like that. Although those are the sensational injuries that you'll hear about, most of us in our day-to-day practice will see, sedentary office type players and workers with back pain. And that can be due to poor ergonomics, Or again, even if you're not lifting heavy stuff at construction, if there is some lifting involved at your workplace, inadequate lifting techniques or repetitive motion can cause these types of back pain flare-ups and injuries. Deconditioning is a big factor to think about. So your host, meaning the person, the patient or employees, body habitus, their day-to-day cardiovascular activity, all of that is a contributing risk factor. So we need to discuss that with them when taking a history. And again, as mentioned before, job dissatisfaction, workplace stress, those are big, big risk factors. Clinical evaluation. So, when we see patients who present with low back pain, work-related or otherwise, just as we learned in medical school, the first step to good patient diagnosis is to take a detailed history. So history includes mechanism of injury. So again, seldom for outpatient practice or office-based practice or occupational health. It's seldom that we're going to see, a construction worker who fell 15 feet, 20 feet, and they walk into our clinic. Those patients tend to, seek out EMS and emergency room care and trauma evaluations at an earlier point. But of course, if somebody somehow did have a significant mechanism of injury and they were able to walk off the workplace and then later started having any major neurologic symptoms or back pain that's concerning for instability, it's critical to kind of keep an eye out for that and to, essentially immobilize those patients and get them straight to the ER, because that's sort of a multidisciplinary team assessment to make sure there's no spinal instability. But the vast majority of people that we'll be dealing with are going to be walk-ins with sort of either an acute onset of back pain without a significant trauma or fall in the subacute or chronic back pain issues. So onset and duration of symptoms are important because often we're asked to kind of discuss or come up with a way of attributing causality as to whether workplace circumstances or a specific workplace injury resulted in this. So back pain is tough in that sense. The vast majority of adults will experience back pain, and most people, it just may be sort of a dormant issue that presents itself at the workplace. Doesn't mean it's causally related, or it's an exacerbation of a pre-existing degenerative problem, which we'll get into shortly here. So it's important to know what their pain characteristics are, what their actual work demands are. Are they working, sitting down? Are they standing? Do they have to do a lot of bending, twisting, things like that? Important to kind of look out for some yellow flags. And that's really a pre-existing history of low back pain or prior imaging studies or workup for back pain. And also patients who have significant fear avoidance, catastrophizing of their pain or compensation concerns or litigation. Those should, kind of raise a specter of extra vigilance when taking the history. Doesn't mean they're faking it. You just have to kind of put that in your differential and work those patients up timely and appropriately. And then again, red flags we talked about: somebody who has fevers, chills, unintentional weight loss, bowel bladder dysfunction, or progressive neurological decline. They, are put in a separate category, and that requires a very timely imaging and data collection so we can further diagnose them and provide them with treatment. Physical examination is the next step. And again, we learned this in medical school: inspection, palpation. But for the spine, there's no auscultation. You kind of go on with a specific neurological exam and do some special testing. So here I'd like to, next talk about imaging studies. Diagnostic imaging studies are very important to evaluate patients who have either subacute or chronic spine problems, meaning not the first 4 to 6 weeks with a normal exam, but someone who's had either chronic back pain or repetitive episodes of flare-up and have not improved with 4 to 6 weeks of conservative care. You'll often need to get, imaging studies plus or minus labs to better assess and come up with a more specific diagnosis than, a lumbar sprain or strain. So here we'll take a couple, the next few slides here, I'm going to take a slight tangent from the workplace because this is actually probably what most of us will see most commonly. And these conditions are actually most commonly the conditions underlying for workplace disability or workplace related low back pain complaints. So degeneration, what does that mean? That means deterioration of tissue or, organ structures that diminishes function. or causes an impairment in structure. So, the picture to your left is going to be a picture of a normal disc height, normal sagittal view of the spine. And then here you can see how these discs have worn down. Not everybody with these changes will have symptoms, and that's what's tricky about spine. You don't want to treat images, you don't want to treat X-rays and MRIs, you want to treat patients and their, symptoms, and most patients you can manage with conservative means. So etiology for degenerative changes, really, it's multifactorial. The vast majority of it is a combination of genetics and aging process. There are some patient factors that can, increase the chances of degenerative changes. That's obesity, smoking, prior injury, or some form of a deformity, whether it's severe scoliosis or kyphosis. And occupational hazards is a smaller component of this, but certainly that can also lead to having more back pain and back symptoms. Pathophysiology for degenerative changes, really what happens is initially you start off with changes within the disc. The disc is the anterior column of the spine, and as you start losing water content of the disc space narrows, and what that does is it ends up putting more loads. So these pictures, for example, on the right side, this column, this is the MRI of a disc, and then these joints in the back that I'm using my cursor, hopefully you can see it, they are the facet joints. So a normal, healthy-looking disc should also be accompanied by normal facet joints. But as the disc starts showing signs of darkening, so this disc is darker in appearance, that means the water content is low. As the disc starts narrowing, it starts putting more pressure on the posterior column or the facets. And here you can see how there's fluid in the facet joint, irregularity, and so the problem starts often in the disc that it ends up accompanying the whole spine. And then you end up getting marginal osteophytes, ligamentum flavum hypertrophy, and this could lead to, spinal stenosis, deformity, things like that. So when evaluating a patient with back pain without any severe traumatic accidents or traumatic injury associated with it, they are likely to fall under these three main categories. So again, the exception is somebody with a high mechanism of injury, high-speed motor vehicle collision, fall from a motorcycle, fall from a very significant height, things of that nature. You have to rule out fractures, dislocations, things like that, and make sure the spine's not unstable. But the vast majority of people that'll seek out back pain related, care and walk into our offices will have some underlying degenerative condition. And the way we examine them and think about them, it's best to try to put them, and they're never neatly placed into one of these three categories, but you do your best to try to see, is it mechanical back pain without neurologic symptoms, or does this patient have some form of a lumbar radiculopathy or stenosis related symptoms? So the next few slides will kind of go over how do we parse that out? How do we come to those decisions for patient care? So lumbar radiculopathy, this is a common pathology that we'll see patients for back pain with associated leg symptoms. So euphemistically, most people, will hear about either their colleagues, friends, or patients talk about how they have sciatica. Sciatica really is a term that a lot of people use for sciatic nerve compression, but the reality is the underlying disease process or pathology is multi-level lumbar nerve root compression or lumbar radiculopathy. Patients present with pain, not just in the back, but pain traveling down into the leg. And we've probably all seen this dermatomal chart. These dermatomes, this is sort of what, I guess I can nerd out or geek out about spine. This is what's really cool about spine evaluations. If you understand these dermatomes, it's very easy to come up with these diagnoses without even looking at an MRI. And that's quite satisfying. You can come up with a nerve root compression and make these diagnoses as long as you're familiar with this. So vast majority of lumbar radiculopathy or nerve compression happens in the lower lumbar spine, and we'll talk specifically about the L4-5 and L5-S1 disc space. But sciatica patients or patients with radiculopathy have pain down the leg. On exam, they'll have positive tension signs. You do always want to ask about bowel bladder changes, and the main reason to do that is you never want to miss a cauda equina patient. So pathology for lumbar radiculopathy typically is a herniated disc, but other issues, including diabetes, tumors, trauma, they can also result in nerve root compression. This is a typical MRI appearance of somebody who's had a disc herniation. And, I will often see somebody, whether security or nursing staff or, social worker at our health system who has nerve root related symptoms. And on MRI, they will have a finding that's suggestive of a disc herniation. Once they've failed conservative care, we sort of get these MRIs and find these treatments so we can timely and appropriately treat these patients. So lumbar radiculopathy has a bimodal appearance, usually happens either in the younger patients in their late teen to early 20s and 30s with a soft disc presentation, or it can happen in an older patient, above 50 to 60, where they have underlying degenerative changes and they can have a hard calcified disc or foraminal stenosis. Again, like we talked about, the first step in making the diagnosis is start with a good history, then we do an examination. And this is kind of part of the examination that's important to kind of have some familiarity with. People with, an L4 nerve root compression will have numbness, tingling towards the medial aspect of the foot and anterior aspect of the shin. L5 nerve root compression will lead to diminished sensation on the dorsum of the foot, the first web space, and S1 usually is the lateral foot or the plantar foot. And then the motor examination, similarly, you can isolate which nerve is impinged based on their motor weakness or sensory dysesthesias. So on motor exam, you'll ask them to extend their foot up. If there is weakness about the ankle dorsiflexion, you know that the L4 nerve root is involved. If their big toe or multiple toes can't be raised up, that's an L5 nerve. And then plantar flexion or lateral rotation or eversion of the foot is more the S1 nerve. From a reflex exam perspective, there's no L5 reflex, but L4 is the knee jerk or the knee reflex, and then S1 is the Achilles reflex. So anybody doing a thorough, neurologic exam for back pain complaints should have some familiarity with these things. And again, just as a summary slide, multiple nerve roots make up the sciatic nerve. So L3 all the way down to S2. And you want to try to isolate the specific spinal level that this problem could be originating from. So for an L4 nerve root problem, you do a motor, reflex, and sensory exam. And you similarly will do that for the other areas. So L5 and S1 nerve roots will have these specific findings. So we talked a little bit about tension signs. So tension signs are signs that kind of cause nerve root aggravation and produce symptoms or make patients uncomfortable. So most of us have heard of or are familiar with the straight leg raise. That's a test to look for nerve root impingement, typically from a disc herniation. This is a pretty specific and sensitive test. More specific test is something called contralateral leg raise. So if somebody has pain that's what they call sciatic pain on the left side, and they're having reproducible pain down the left side from a right-sided exam, that's a pretty high specificity that they have a disc herniation or nerve compression. Femoral stretch test is more for the upper lumbar, L2, 3, 4 areas, where you can either do that supine or you can do it in a lateral position where you're extending the hip and bending the knee. Actually, sorry, this is a prone position exam, and that will help figure out whether they're having reproducible pain because of nerve tension. So the next category of patients, so we've just covered disc herniations or lumbar radiculopathy, but the next category is patients who have spinal stenosis and pseudoclaudication or neurogenic claudication. How do they generally present? Well, obviously nobody, most patients and, even healthcare workers, we won't walk into the office saying, well, I have spinal stenosis and these are my symptoms. Patients may throw some of these words around, but it's up to us as healthcare providers and physicians and practitioners to figure out whether that's their true diagnosis or not. So people with spinal stenosis will typically present with some form of back pain, but they'll have this heavy sensation traveling down their legs. And it's usually bilateral. Rarely it can be unilateral, but pain generally is in the back of their thighs as well as their calves. They feel worse with walking. They generally tend to have these signs called shopping cart sign or toothbrush sign, where you see patients leaning on the cart or on a sink and feeling better. When you get a history from these patients, they'll typically say, well, I can walk 1 or 2 blocks and then I have to lean on something or sit down and then I can do another 2 blocks. Those are pretty typical, findings of somebody with spinal stenosis. And again, you want to make sure they're not having any saddle numbness, anesthesia, or bowel bladder symptoms. The pathology for spinal stenosis is usually not a specific traumatic event unless there's a bad fracture with significant bone fragments that are causing nerve compression. This is typically things that take time. You develop arthritis, you develop disc bulging, and over time it causes nerve compression. So osteoarthritis, congenital spinal narrowing, and patients who are achondroplastic are at risk factors for this. They can generally get significant spinal stenosis. And again, you start off with a good history and then do a focal neurologic and physical examination to figure out, what the patient's issue is. So I mentioned this term before, and again, you learn about this going back to med school days, cauda equina syndrome. It's a surgical emergency. For cauda equina, you have to make sure that the patient does not have any loss of bowel or bladder function, any difficulty with sexual function, or any saddle numbness. If they are having any or combination of these symptoms with crushing back pain, they need to be sent to the emergency room for an urgent MRI, as a decompression surgery has to be performed within 24 hours or less. The longer you wait on this, the more permanent these neurologic losses can be. And this is a pretty significant reason why physicians can get sued for mismanaging spinal care. So last category, and this is kind of the category that most people will see in occupational medicine, but also in spine or pain management fields, where people are coming in with mechanical back pain. And what that means is that they may have some neurologic findings, but their main predominant complaint is back pain. Back pain complaints, can vary for various reasons. It's pain because patients have mostly arthritic changes of their spine. It could also be pain from, degenerative posture, things like that. Sometimes you can have pain that radiates to the posterior thigh beyond the knees, but most of the patients will have axial back pain without associated leg symptoms. So mechanical back pain can happen from simple things like muscle strain or ligamentous sprain. It can happen for patients with degenerative disc disease or patient with spondylosis or arthritis, but it can also happen for patients who have something called spondylolysis, which is a fragility fracture or a stress fracture of the spine in the pars area, or someone who has a spondylolisthesis. And we'll talk a little bit more about that in a second. And just the same theme as we've been talking all along, you get majority of your diagnosis from a detailed history, and you can sort of associate this with either a run-of-the-mill degenerative problem or something that can be causally related to the workplace if there was a specific event. And then it's important, again, to talk about non-organic pain. So, the spine, again, we talked about in the first few slides, is low back pain is a big economic impact on productivity, 100 billion plus lost wages and, lost productivity per year, including treatments rendered for back pain. So some of the things you can do is look for Waddell signs, and these are patients who have hyperesthesias or severe pain with even the lightest touch, patients who have it's non-anatomic reasons for having back pain. So gentle head compression causes severe back pain, or if you ask them to kind of rotate their shoulders by twisting, they're talking about severe low back pain, or having non-concordant straight leg raise. Things, this is just a picture where you could do a straight leg raise in a seated position versus a supine position. And if there's no concordance between these two exams, that should raise some, red flags in your mind. Also, to assess participation, sometimes you'll have to put your hand on the contralateral heel, and then ask the patient to lift up their legs. So theoretically, if they're giving full effort, you should feel more pressure on the contralateral heel. But if they're hardly raising up their leg, then you know that their participation in the exam is not quite there. And it requires further testing to pin down the diagnosis. Further testing, once you think that this is a subacute or chronic back problem, or there's any concerns for neurologic association, will require X-rays, including flexion extension X-rays if the spine is not unstable, and generally advanced imaging. MRI is really the imaging of choice to look for any kind of neurologic concerns or impingement. Some patients, however, cannot get an MRI because of old pacemakers or heart valves. Some of the newer technology is MRI compatible. In those cases, you might need to do a CT scan or a CT myelogram. So once you've kind of gone through your rigorous history, physical, and diagnostics, you want to classify back pain into kind of one of these categories. And that means initially you can either classify them as a temporally oriented classification, meaning somebody who has less than 6 weeks of back pain, that's an acute back pain. Someone in 6 to 12 weeks is a subacute problem or a chronic problem if it's greater than 12 weeks, or multiple flare-ups routinely over the course of years. The other way we classify this is sort of mechanistically or etiologically. That means, does somebody have a mechanical back problem? And that really means patients who have pain with flexing their spine, pain with certain activities, pain with bending, twisting, and that tells us that there's a mechanical component to their back pain. And that could be either due to a strain, could be due to discogenic arthritic problems, or even a fracture. Non-mechanical pain is, pain at rest, pain that's worse even at nighttime. And so those are part of the red flags. That means it's not mechanically induced, so you have to rule out inflammatory conditions, infections, tumors. And then you can also divide the mechanical pain into radicular or neurologic pain, with stenosis or herniation being part of your diagnosis. So once you've made the diagnosis, how do we treat patients either at the workplace or even non-work related back pain? So key is, in the old days, bed rest was prescribed. We've come a long way from that. We know that that's actually quite detrimental and you want to avoid bed rest. And you can have some activity modification, but you do encourage general activity, walking, as much as tolerated, so that you can, one, psychosocially help the patient, but also help their back muscles and their discs continue to get some nutrition. Discs are generally avascular. The only way they get nutrition is through movement and activity, and gentle activity is encouraged. Early physical therapy has been shown to help patients manage their pain better and get out of their back spasms and the stress, the social stresses involved with back pain episodes faster. NSAIDs are a good adjunct. Short-term muscle relaxants can be considered, but a lot of this in the acute phase, with the absence of any neurologic concerns, really leads to early diagnosis, education, activity, and reassurance for the patients. If it's workplace related, you also kind of want to get a sense early on about the ergonomics and setup at work and what you can do to help minimize those barriers to return to work. So non-pharmacotherapy is really predominantly physical therapy in the acute phase, and this should concentrate on core strengthening, flexibility, joint mobilization, and some manual treatment to get the soft tissues moving. If it's more of a chronic or subacute problem, that's where you might have to institute other ways of getting people back to their normal lifestyle. And that sometimes includes cognitive behavioral therapy. And this is to work more on the psychosocial impact and how patients are psychologically handling this, in addition to physical therapy. Functional restoration is something, that I, as a physician, I don't necessarily participate in myself actively, but I will make some referrals and I'll be curious to hear what the group here does with their functional capacity evaluations or functional restoration for patients to get them back to the workplace. Usually can be divided into either work conditioning or work hardening. And what that really means is work conditioning is more of a physical therapy and physical based program where you're really working mostly to kind of simulate some of the workplace activities, or you try to figure out the maximum loads and activities a patient can do. Work hardening can be a combination of what I said above, plus some psychosocial interventions as well to try to figure out what the best way is. This will take a fairly motivated patient who wants to participate in this in order for this to work. And you can also have a multidisciplinary rehab program where, again, you're not just addressing the physical needs for the patient, but also addressing some of their psychosocial barriers and issues. And then pharmacologic therapy. So pharmacologic therapy is fairly common and often helpful in getting the patients over the initial inflammatory phase of their back pain. But the first line really is NSAIDs, and for patients who cannot tolerate NSAIDs, acetaminophen. You want to avoid opiates at all costs. I think most of us in 2025 understand this well. There was a time frame where there was probably overprescription of opiate medications, especially for back pain, which is probably a common reason why people take opiates. But most of us, I think, understand this well, that it leads to poor long-term outcomes and dependence. So not a good drug of choice, especially in the early onset. Muscle relaxants can work, but avoid benzos if possible, or muscle relaxers that make patients fairly drowsy and incompetent, sort of unproductive may not be a good idea. There are several that you can prescribe that don't have the same drowsy sort of side effects, and these could include scalaxin, Robaxin, even baclofen, things like that. Neuropathic medications like gabapentinoids, Lyrica, they do have a role, but that's only if there's significant neuropathic component to the pain, or if it's a subacute to chronic issue, then you can consider it as part of your multimodal pain assessment or treatment. And then topicals, whether it's topical Voltaren or diclofenac or other topical ointments, they can help. When do we seek out, or when do we prescribe pain management interventions? Well, again, if it's a first episode of acute back pain without any significant neurologic concerns, you want to deal with these patients with physical therapy, reassurance, and mobility and activity modification. But if they're in the subacute to chronic phase and they're having neurologic issues, then they, will need an appropriate workup, including an MRI. And if there's evidence of some form of nerve compression or spinal stenosis, only then is an epidural worth considering. Epidurals are not good interventions for back pain. They're better interventions for nerve-related symptoms or radicular pain. If someone has predominant mechanical back pain, that's recalcitrant to physical therapy and anti-inflammatory medications, then and their MRI does not show any specific neurologic compression, it's mostly degenerative changes. That's when you do facet-based interventions, something like a medial branch block. And if that works, you can consider something called an ablation or a rhizotomy. Now, there's other interventions, some advanced interventions, including ablation of the sinovertebral or basivertebral nerve, if you think it's mostly mechanical back pain due to that nerve irritation. But generally, these interventions are reserved for patients with a specific diagnosis after failure of initial conservative care with MRI confirmed diagnoses. So surgical options. This is clearly the last option. And even though I'm a surgeon and that's sort of my general motivation, and in terms of my conflict, that would be the one conflict that I would say. I'm a surgeon, so I will talk a little bit more happily about surgical interventions, but I will be the first one to say that surgery for run-of-the-mill back pain has almost limited to no role. Surgery should only be prescribed for patients who either have cauda equina syndrome, progressive neurologic deficits or neurologic deficits that are not improving with conservative care. And you want to give them at least a 6 to 12-week trial of conservative treatment, which includes physical therapy as well as pain management interventions if needed. And you have to have imaging studies that show either spinal stenosis, nerve compression, or instability. Surgery for those diagnoses actually have an excellent track record, but surgery just for back pain without any structural abnormalities, with just a little dark disc disease, those patients do not do well, and I don't recommend surgery for that patient. Sorry if anybody is squeamish here. I also wanted to put that in that surgery, this is not, as they say, your father's surgery. There's newer ways to doing it. So those of us like myself who basically dedicate minimally our surgical practice to minimally invasive spine surgery can often address these things with much less invasive ways. So, this is sort of a typical picture of how if a microdiscectomy or decompression needed to be performed, we would do it this way versus the original or the, old-fashioned way. I think we have a couple of seconds, so I'm just going to play this quick video that shows that you can very easily do a decompression of the spine or spinal nerve roots, again, using minimally invasive approaches. So just as a guide, we're looking down, oops, sorry about that. We're looking down this minimally invasive portal. This is about a 1.5 centimeter portal. And what we're doing is decompressing the compression off the nerves. So the left side is the head, the right side is the foot, and up top on the screen is the midline of the spine. And you just see me removing certain fragments of bone as well as compression from ligament to take the pressure off the spinal nerves and the thecal sac. So this white, tissue that you see underneath is the dura. And again, through these specialized tools, what we do is we can very easily decompress the spine and open up the space for the spinal nerves without causing more instability, without causing catastrophic injury to the normal healthy muscle tissue. So we all understand that having good, strong back musculature and, physical therapy, the tenet of therapy is to have good core strength. That's very, very important in not just treating the episode of back pain, but also to help with preventing future back pain related problems. So this sort of, video just highlights that you can do that fairly well with minimally invasive approach. So getting back to kind of coming up with a general approach or rubric of how do we treat people with occupational low back pain. There's many different acronyms and sort of approaches available out there, but I kind of like this SPICE sort of approach. What it really stands for is simplicity, proximity, immediacy, and centrality, as well as expectancy. And what that means is keep things simple. When you first see somebody with an acute back problem, without any red flags or yellow flags, avoid unnecessary tests or treatments or delays. Proximity is important because you want to have multiple follow-ups with these patients, or if it's an employee, so that you can figure out what are their concerns, how are they progressing, so that you can get them back to their normal. It's not just all about employment and getting back to meaningful employment. It's really to get back to their normal lifestyle, so you don't let the psychological and physical impact of back pain sort of seep in and become a chronic problem. Immediacy, if somebody has back pain, especially related to the workplace, you don't want to delay care. You want to get them in as early as possible. And then centrality just means that all the people involved in, managing back pain, especially when it comes to workplace-related back pain, should have a shared common goal and communicate effectively. And the goal should be, remove the patient's pain, enhance their recovery, and also get them back again to their quality of life, as well as productivity and meaningful work. And then expectancy, it's important to discuss what your goals are from treatment and what the patient's goals are, because mismatch and miscommunication can often lead to, protracted, disability or inhibition from returning back to normal activities. So again, open communication, I can't stress that enough from a workplace management perspective. Communicate with the patient who may be the worker, communicate with their employer or insurer as needed, so you can all be on the same page. So treatments that you think are necessary for the patient aren't getting denied. There is, if you're dealing with workers' compensation, there's a lot of red tape associated with it. So it is important to kind of have a good workflow. Otherwise, this leads to unnecessary delay in care and dissatisfaction with care. Frequent follow-ups, as mentioned before, are critical to kind of assess any further barriers and to get people back to their normal life early on. As opposed to keeping people out of work, it's better to give them some work modification, light duty, so you can encourage just, the act of having a routine, getting up, going to work and coming back without doing anything physical is a good way to keep them moving, keep the back strong, and keep the psychosocial, issues associated with these episodes to a minimum. And there's several studies that show that, early return to work within 7 days improves long-term outcomes. Majority of patients, fortunately, with occupational low back pain do return to work within 6 months. But you can see that if they don't, so this statistic, for example, is generally about 70% of the people can go back within 4 weeks and 86% within 6 weeks, and hopefully about 90% or so at the 6 month mark. If you can't get them back, the chances of going back to work after 6 months drop significantly. It's also important to address any ergonomic issues from the workplace, so assess the workplace, make modification, provide patients with mechanical aids if needed, and again, education and counseling. So key takeaways: most acute low back pain improves in 4 to 6 weeks. Avoid unnecessary imaging workup. Focus on the patient's function and don't catastrophize their pain. Early physical therapy and counseling to avoid fear is critical. Address any barriers to continued work or return to work. And again, return to work is 50% only at 6 months if you're in that 10% range, and at 2 years, virtually nobody goes back to work.